All right. Stop share and reshare because the last time I did this, it did not look over this mistake. All right, so cardiac disorders that affect what happens with the heart pump, and if it can't pump enough to meet the demand of oxygen perfusion in the body, right? We know that leads to organ failure. It's not getting blood, the organ's not going to be healthy. So when we talk about our main cardiac disorders, usually we're talking about heart failure, right? This is the most common one. And it may be something that is acute. It could be chronic, so it could be temporary or it could be ongoing. And it's when it's unable to meet the needs of the body, right? And in order, it says metabolic demands, that is the exchange of oxygen, carbon dioxide to perfuse the tissues. Normally we see this with coronary heart disease, and we see it with myocardial infarction, which we just talked about last week, right? So if you are going from last week's material, this is a perfect stepping stone to this week's. Okay. Risk factors, we went over these before, so you know what this means. When you have ischemia from that coronary heart disease, right? That's that atherosclerosis, the plaque, the buildup, the narrowing, the lack of perfusion, we get the ischemia, right? That's where we have the tissues that are starved, that's where we get some chest pain. So if we have that pain, we know that we are obviously causing heart muscle have some damage, eventually, right? 75% of the people that have high blood pressure, especially those that are untreated, are going to end up with heart failure. And if you have heart failure, it doesn't mean that you know you have it, right? So a lot of people have that sudden cardiac death. They just drop over. And then when they look into things, they see, oh, they had dilated or hypertrophic or whatever. This is a really sobering statistic that when people do get diagnosed, by the time they get diagnosed with heart failure, their longevity is not super long. Now, we have lots of interventions, but just know that once your heart starts to fail, there's not a quick cure that we can do to try to reverse it. Okay, this you do need to know. You need to know how to calculate cardiac output because we talk about it all the time. We're going to talk about it more today. So that is the amount that you're pumping out multiplied by how many times a minute your heart beats, right? So that is what we consider our cardiac output, okay? So it's like a math question, but not really. Just understanding we're talking about cardiac output, that's what we mean. So when we were talking, Olivia, about beta blockers, right? When we talk about the heart rate, yes, it will drop it, but because there's longer filling time, the amount they're going to pump out is more. So that is a way to improve the cardiac output. Okay, so these terms we've been talking about all the way through, right? Preload, afterload, end-diastolic volume, all those things, right? Our contractility, when you look at your med list, we have our inotropic, the ones that increase the squeeze, right? And we have our ejection fraction. Go back to this picture. I really like this. It kind of helps. You have the venous return. We have our diastole. The heart is resting. It's filling up. We have our preload, which is how much it's going to stretch to fill. And this is our volume, right? How much is going to be in that ventricle. Then we squeeze. That's our systole. What we squeeze against is our afterload. That's how high our blood pressure is, how narrow our vessels are. Our stroke volume is how much we can get out at a time, okay? Then we have our end systolic volume, which is how much is left after the squeeze, okay? Just to kind of get in our head what those different things mean. The next thing we're going to do is look at some compensatory mechanisms that go with CHF, okay? We're going to talk about these here in a minute.
Providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Okay. So a quick, just a quick view of what we are talking about with this compensatory mechanisms, right, in that video. So some of them are in the heart, but some of them also have to do with the kidney itself. Okay, and we know that those tie together, especially when we're looking at our medications for CHF and for high blood pressure, they're all tied together. So the first mechanism that it talked about in that video is it's called Frank startling. Okay, and what that means is that once it is stretched, overstretched, it's not going to be able to squeeze as effectively. Okay, and I put a picture of a deflated balloon over here because that's what happens. The heart then has all this extra muscle, but it doesn't actually contract, so it becomes kind of that floppy. So because it doesn't bounce back into shape, that pump is not as effective. Okay, so it's called a Frank startling mechanism. What you need to know of that is just that when it's overstretched, it's not going to have the good squeeze power. Okay. The other thing is that neuroendocrine response, which is what I talked about in that video. And that is because our cardiac output is not as good, the kidneys interpret that to mean our blood volume must be low. We better start retaining salt and fluid to try to increase our blood volume. Because the heart is not pumping, our cardiac output's not good, it's trying to fix it by doing its part. So what it's going to do is it's going to stimulate that aldosterone to retain, right? Which then also activates the nervous system, which says, okay, now that we have this extra salt and fluid, now we need to beat faster to try to get this volume up. If your heart is already weak, that extra volume and that extra activity of the heart, the higher heart rate and the higher blood pressure is going to, again, more afterload, it's going to tax that heart that's already not working. Okay, so again, here's a picture. You've got your kidney's not getting enough blood. It starts to stimulate and start its cascade until it retains more water and vasoconstricts. Now, what do you see right here? Why do those two words look familiar? The angiotensin. What are one of the medications we use for this? We use our ARBs and our ACE inhibitors, our angiotensin converting enzymes, right, and our aldosterone. So that's why these two medications are really important when we're talking about heart failure. So if you haven't gone back and looked at those pills, looked at those sartans, take a look. That's where this falls into the place. Okay. So what happens when we have these two mechanisms is our tachycardia, our faster heart rate, decreases the amount of time it takes to fill. Remember, now this heart is an overstretched balloon and it's kind of floppy. So it's bigger, so it needs more time. So as the heart rate jacks up, it doesn't have the time to fill completely, okay? And then also, again, if we have this extra fluid and the salt and the volume, if that heart's not filling all the way, it's gonna back up, and then we end up with fluid that leaks into the lungs, and we have that congestion, right? So ventricular hypertrophy is the third mechanism that the body tries to fix. So we know that that heart is starting to stretch and get floppy. So what does it do? It thinks I'll make more muscle, right? I'll just make this muscle bigger and then it'll pump better, right? Which does work temporarily. But when you have a muscle that's bigger and it is pumping a little better temporarily, but then it needs more muscle. It has more muscle that needs to be fed with oxygen and with blood to itself, which again increases your ischemia, right? So if you have more muscle, it makes sense, it needs more oxygen. Also, again, just because the chamber size is thicker doesn't mean that that chamber is bigger, right? As it gets thicker, it sometimes goes thicker inward, which shrinks the amount of volume it can have. So 3 different types of ways the body tries to compensate. And they do work temporarily, which is why people sometimes don't even know they have heart failure until they have chest pain, until they have an echo done, and all of a sudden we're seeing all these changes to the heart and to the blood pressure. When you do an echocardiogram, that's the ultrasound, you can see where the thicker the wall is here, right, the smaller the chamber you have. Okay, so again, that's why we're gonna have these lisinoprils, we're gonna have to have our ACE inhibitors and our ARBs, and we're gonna have to have our beta blockers, because we have to kind of take the body's natural responses, kind of knock them down a little bit so that we don't affect the heart too much. Okay, so long-term damages the pumping ability. So these temporary fixes don't last in the long term. The body just can't handle it. Okay, and then we develop our heart failure, right? 4 types of heart failure we're going to talk about. Okay, we should look familiar. So far, this stuff is not brand new, right? Okay, so here's our 4 types. You do need to know the 4 types. The first one is systolic compared with diastolic. And I tried to do side-by-side comparisons, and I tried to keep the colors the same, so you can kind of go across the chart and see. So let's start with systolic. Okay, and that is where it does not contract enough. It doesn't squeeze enough to get the blood out, versus diastolic, which is it doesn't relax enough to fill, right? So one's a squeeze and one is a fill. So this one on the systolic side is caused by loss of cardiac cells, right? We know that that happens when we have some type of perfusion issue, we have an oxygen issue. That's where you get your heart attacks. That's where you get your ischemia, your cardiomyopathies. We have a lower cardiac output. And what does that look like? You know, your heart can't keep up with what you're doing. You get activity intolerance, you're weak, you're fatigued. And we see a reduced ejection fraction with systolic heart failure. Okay, your EF is 40. Okay, you've got this flabby ventricle that won't go ahead and squeeze, right? And we know our EF should be what? 50 to 70, right? So 40, you're going to be symptomatic because your EF is below 40. Okay, over on this side, it's caused by a stretching problem, right? A preload problem. So because this can't relax enough, it can't fill well and it can't squeeze. Okay, so hypertension, we call it the silent killer. If your heart has been pumping against high blood pressure your whole life, that it's going to be very stiff and thick. Okay, sleep apnea is a huge component of this. People don't even realize they have sleep apnea. Your body tries to compensate from that decrease in oxygen all night long, and it gets thicker. Okay, so we have increased pressure behind that ventricle, and so what do you see? You see shortness of breath, especially when you try to lay flat at night. Everything backs up, right? Left ventricle, it is getting all its blood flow from the lungs, right, from those pulmonary coming into it. And so if it can't relax and it can't squeeze, it's causing an upstream problem, which goes right into the lung, right? So extended neck veins, cough. But if we do an echo, we call this preserved ejection fraction. So even though you've got all this going on and it is heart failure, your EF is still going to be above 50. Again, you might not even know you have it because your body is compensating pretty well until it doesn't. But when you look at the ultrasound, you look at your echo, you're going to see a thick and bulky ventricle, right? That's the difference between the two. Make sense? Yep. Okay. So what do those lead to? Left-sided and right-sided. Okay. Left-sided is going to be, again, where's the problem? Left ventricle. What is directly before that left ventricle upstream is your lungs. Okay, so we're gonna have pulmonary congestion. This is where you're gonna get those F3 sounds, right? Those extra closing sounds, orthopnea, frothy sputum, anything wet. We're thinking with left-sided. Okay, so backing it up to the lungs, decreasing what's going out to the body, right? So left-sided, we think really wet lung symptoms. Where right-sided, okay, oftentimes comes from the left side being inadequate, eventually it affects the right side. Okay, so this is going to be a pulmonary circulation problem, meaning what is upstream of your lungs is the rest of your body. Okay, so this is where you have stuff in the body itself, not the lungs necessarily, but the body. This is where you get the abdominal congestion, the swollen legs. You get poor perfusion and modeling. You don't want to eat because all of your portal veins and everything are all backing up. You have weight gain, right? So upstream of wherever that ventricle is the rest of the body. So this is going to be swelling everywhere else. Left side is going to be swelling in the lungs. Does that make sense? Okay, so if you had a test question and it said, you have a person who is presenting with scrotal edema and pedal edema and anorexia and ascites in the abdomen, which side would that be?
Right.
Okay, and conversely, if you have somebody who's got a ventricular gallop, they have orthopnea, they can't tolerate laying flat at all, and they have this frothy cough, left side. Make sense? Okay. So there is a kind that's called high output, right? And again, this is what happens when your body tries to compensate. It can for a while. It doesn't mean you're not in heart failure. It just means you might not be asymptomatic. What we see with this though is tachycardia and palpitations. Okay, so this is a heart failure. Your heart is beating the right way, and it's not a problem with the pump. It's just the heart can't meet the increased need your body has, right? This is a 600-pound leg person who's, 30 years old, but weighs 600 pounds, and there's nothing wrong with your heart. There's nothing, you never had a heart attack, you don't have blood pressure, there's nothing that's causing it, but it just can't beat enough to meet your needs, and it wears itself out. Okay, so obesity is usually what we see, but also if you have some type of a metabolic disorder, sometimes thyroid, sometimes adrenal, where your metabolism is requiring more oxygen, it's not a matter of the heart, it's another process that is not getting its need met by the heart, which eventually fails. Does that make sense? Have you heard of this kind before? Okay, but it makes sense though, right? Like if your heart is beating for like 3 sizes too big, it makes sense why you have some failure, right? Okay. Acute versus chronic. We know acute and chronic, we know what those terms mean. So we may have acute onset a lot of times with an initial myocardial injury. Okay. So we have a sudden decrease in our function, like with an MI. Okay. Whereas chronic, again, is the one that develops over time. And with the chronic, you're going to see a lot more of the compensatory things because your heart has had time to adjust and change. Your kidneys have had time to adjust and change. And so we see this one much more commonly. Okay. And then we have this term which we throw around in nursing, which is acute on chronic, which means you have something that's happened for a really long time, but now all of a sudden it's a big problem, right? And that's the sudden worsening of something you had. Okay. So an example of this. So my mother-in-law went to the ER, and if you already heard this story, I'm sorry that you have to listen because I'm not here. So my mother-in-law went to the ER during COVID, and she had pain in her ear, and she had a cough, and she was fatigued, and so immediately, right, they put her in COVID protocol, and her blood pressure was a little low, so they gave her a liter of fluid. Okay. She did not tell them about her family history, about her bad heart valve, about the fact that she had 2 stents placed. It was her fault, right? She didn't give them any history. And so what happened was she was actually experiencing acute coronary syndrome. But presentation with women, we know it doesn't follow that typical crushing left arm, jaw. Hers were very big, right? Neck to knees. She was having some vague symptoms. So they went ahead and loaded her with a liter of fluid. Instantly put her into congestive heart failure because she was experiencing acute coronary syndrome, which wasn't recognized, right? Her troponins weren't back yet, 3 kg, just maybe a little depression, but nothing that was really screaming at her. And you added that extra liter of fluid and she instantly flooded her lungs and had to be put on BiPAP tube and sent to Columbus. Okay, so it can happen very quickly. If there is something going on that is not caught, we can put people in acute heart failure pretty quickly. Okay, so that's why when we were talking about our MI patient, when we were in the lab the other day, we talked about how their blood pressure might drop with the nitrate and the morphine. We have to be cautious in how we raise that pressure. We want to go slowly with the fluids or use vasopressor type medications instead of just doing those huge boluses that we're used to everything else. Okay. Are you with me so far?
I thought I was invincible I was in the oil and gas industry, fighting it out in a man's world. I loved every minute of it. When I found out I had heart failure, I was completely in denial. And I just remember that my life would never be the same. And it was hard. My name is Myra, and 10 years ago, at the age of 43, I had a massive heart attack. It totally came out of the blue. I remember going to bed and trying to fall asleep, and I started having chest pains. I called my sister. She took me to the hospital. They put me a couple of stents, and I was sent to recovery. At the time of discharge is when I first heard the words heart failure. And honestly, I was shocked. I went into the hospital taking 0 meds, and I left the hospital with 6 prescriptions to fill. She went back to work, which was very stressful, not a nurturing environment for someone who just had a heart attack. I went to my doctor, and I remember him saying, Myra, you might want to rethink your career if you like your life. One of the hardest things in trying to manage heart failure is lack of energy. It's hard to go grocery shopping and push out a cart. It's hard to go up a flight of stairs without huffing and puffing. Shortness of breath, fatigue, coughing spells. I would have to deal with these things on a daily basis. She had to make a change. She had to go to a much less stressful position, work half the time that she was working before. I started Googling my condition, and it was nothing but doom and gloom. And I became so depressed. All these medicines and all these doctors were treating her heart condition, but they weren't treating her lifestyle changes. They weren't treating her depression. My daughter helped me find an organization called Women Heart. Women Heart is a national organization. I was able to hear from heart sisters who were living a great life, even though they had the same thing as me. I always say that my doctor saved my heart, but Women Heart saved my life. I developed a passion to go out and spread the word to other women who may also be feeling alone and isolated and scared, that it's okay and we're here, you're not alone. In Cajun country, we love to eat, drink, and party. That's us. I knew after the heart failure diagnosis that my cooking style needed to change. So I have learned a new way of cooking, and I've found things to make it just as tasty as it was before, just it's a little healthier for us. The Myra I am today is much different from the Myra I was. I feel I'm much healthier in mind, body, and spirit. I just have to do life at a different level than before.
So how old was she when she got diagnosed? 43. When we think of heart failure in our practice and we see our patients, we often think of people in their 40s with heart failure. No, but it happens, and it's becoming more and more frequent between lifestyle and stress and things like that. So even though we looked at that statistic of 8 years prognosis, if they are young and if they're willing to adapt some lifestyle changes, we can get better results. Okay, so when we find our patient, it's important to find out what stage they're in. And if we could identify them here at like stage A or B, where they're at risk or they are pre-heart failure, right? And hopefully we can help the downstream problem, which is then progressing to our later stages. So she did some lifestyle choices, the mental, right? She decreased her stress at work. She found a support group. These are the kind of things that when you have a patient with heart failure, it's good to know the ins and outs of how it happens and all the different mechanisms and things. But we also have to remember we're looking at a patient and we're looking at how to improve their lifestyle and how to educate them so that they can have a higher quality of life. So we use two different things to kind of tell where the patient is at, which we do stages and we do classes, right? So stages are A to D, classes are 1 to 4, and then you can pair a letter with numbers, sort of like cancer staging, to kind of give an idea of where you're at. Okay, when you're diagnosing, a new lab that you need to know is BTNP or BNP. That's your beta type natriuretic peptide, right? BTNP. If you look for it at Ohio Health, when you type it in Epic, you have to put an N in first, and I don't know why. So if you're choosing, like, you can't just like go to the results page and type in BNP because it won't show up. Remember to put an N. But what that does is it's a hormone that your body releases in response to your blood volume. Okay, so again, we know fluid is overloading somewhere because the pump is failing. So under 100 is what we expect. That's our normal value. So if it shows up anywhere between 100 to 300, we know that you do have some type of a fluid overload, right, of that volume change. And then it goes all the way up to above 900, and that is severe heart failure. At that point, it's pretty much just a diagnostic because we can see that you have fluid in your lungs, fluid in your body, you're having trouble breathing, you have activity intolerance. Probably the biggest one I ever saw was over 5,000. They were transplanting quality. They were really, really sick. Okay, so other things we do, these are gonna look really similar to what we have been talking about since the first day of class, right? The different types of tests, the different type of looking at the electrical system of the heart, right? Using the different imaging studies. So this should look very similar to the other slides. Okay, so the BTNP is the new one. You're gonna see this slide in this class. You're gonna see it multiple times in this class. You're gonna see it in the PEDS class, right? Because we have heart failure across the spectrum of age. But here are your goals. Okay, these you need to know. We want to function the best it can be. Gonna get rid of the fluid and sodium, decrease the demands of the heart, get oxygen where it needs to be, and then especially for the adult population, we want to slow the progression. Okay, so start, circulate, whatever you need to do. But when you are looking at test questions based on heart failure, you need to ask yourself, which of these answers is going to meet this goal the best? Okay, so remember those. Our medications, again, these should look very similar, right? In your textbook, here's a box if you want to go back and look at them. But none of these should be brand new. We've been talking about them the whole way through. We have our ACE inhibitors. We have our ARBs. We have our diuretics. Okay, we have loop diuretics as well. So there's two different classes of diuretics. And we have our beta blockers. Okay, again, you keep seeing these because they're really important. All right, when you get to your NCLEX, so much of it's going to be based on medications. What we've been doing is we've kind of been phasing out the trade name. And so because words are only generics. So if these don't look that familiar, right? If furosemide doesn't sound familiar to you, but Lasix does, start to try to remember those generic names because that's what you're going to see on your boards. Okay. Positive inotropic agents. Again, inotropy is that you squeeze. Okay, so that medication is going to be really important. Our example is digoxin. The trade name is Lenoxin, but we do a lot by digoxin. And what that is going to do is that is going to help us squeeze a little bit better. Okay, which is what we want with heart failure. I'm going to move this to the side for a hot second because we want to make sure with this digoxin, it's a medication that we can easily overdose on. So we have to have our labs drawn and make sure we're in a therapeutic range because digoxin toxicity can be very, very serious. So a lot of times patients will say that they see orange or yellow around things. It sort of looks like halos when they look at the light. They're going to have weakness, muscle weakness. They're going to have nausea and vomiting. If you know you have a patient on dig and you have these symptoms, you definitely need to get a therapeutic level drawn ASAP. Because we can administer digoxin immune fab, which is digibind, and we can help to draw it out of the blood. Okay, so it's a great medication. It has a really narrow therapeutic window, and we have to make sure we acknowledge that. Okay, Also, making sure you're recognizing when we don't give DIG, same with beta blockers, right? We take their pulse, and if it's below 60, or we look at their systolic blood pressure, and it's under 100, we're gonna use caution in giving that next dose. Okay, another new med, and of course, this one is starred, because if you look at your medication sheet, and I said we'd be using our chart for all of 2050, this one is on there, right? This is its own class. Another one is the phosphodiesterase inhibitors, and what that means is basically, it is going to cause some vasodilation, and it's another way we can increase our output and decrease the resistance it's pumping against. Okay, so milrinone is one of those medications. But the main one to know is that digoxin. If your heart is so weak, if the congestive heart failure is so pronounced, sometimes we have to put in what's called an LVAD or a VAD, right? A ventricular assist device. This one's called an LVAD because it's in the left ventricle. You can put them in either ventricle, okay? And what that does is this is gonna buy you some time to either get your heart, as healthy as it can be, or as you're waiting for a transplant, okay? So, again.
New Hampshire's Matt Fogg loves playing with his heavy metal band, but it was the collaboration of caregivers at the Heart and Vascular Center that orchestrated his life-saving care.
I was actually doing some flooring and I couldn't walk more than 20 feet without being out of breath and feeling an incredible pressure right here. And a few months went by doing that and it progressively got worse.
When he first presented, he was in what we call cardiogenic shock, which is when the systems of the body were all shutting down as a consequence of the inability of the heart to pump blood.
Basically, he said if I had 9 lives, I used every one of them.
The first course of action was just to stabilize him. He was very close to death. With a variety of intravenous medicines initially, we were able to improve his cardiac function so that the rest of his body could improve. If we couldn't move forward with more advanced therapies, the probability of him dying in the hospital was almost 100%.
You can try medications, you can try pacemakers, but when those fail and the patient continues to deteriorate, VAD is the only other option. VAD is a ventricular assist device. It's surgically implanted, much the same surgery as you'd have for a valve replacement or bypass surgery. It takes care of the plumbing of the heart.
What Leslie really did is she came in with like a VAD, like a demo VAD to show you what it would do. And they had to teach you everything about the VAD, how to change your batteries, how to clean what would be the driveline site, change out your controllers and do all that stuff before you could even get to VAD.
All this was just part of what had to be done before Matt could have the VAD implanted.
We placed a balloon pump, which is a mechanical device that goes in the leg to give him further support. With this, his heart function improved enough so that we can make the decision to move forward with the VAD.
Day of the surgery was really this do or die, no pun intended.
An LVAD is implanted through a sternotomy, which is a typical open heart surgery operation, opening up the entire chest. We core out the nickel-sized hole in the tip of his heart, which is where this pump connects up to. The other end of the pump connects up to the aorta, the main artery leading out of the heart, to pump blood throughout the rest of his body.
The VAD actually unloads the heart. So as a consequence, it allows the heart to get better. The scar tissue tends to reduce and a variety of inflammation or inflammatory markers improve. With this and with good medical therapy, the heart has a chance to undergo what we call reverse remodeling.
Matt went home after a month. He would come to clinic regularly to monitor his medications and any concerns he had with the VAD. There was one setback.
He did have a small stroke, which made things even more complicated because now we had to balance the management of his VAD with the management of the stroke. So the first few weeks were challenging for him hemodynamically, but he got better from that perspective.
Matt improved so much, the doctors looked at the possibility of a rare explantation. Matt couldn't wait.
Take it out today. I have an eye, take it out today. That's what he said. I said, well, we're not gonna take it out today.
So we turned down the support that the VAD provides to the bare minimum. And with that, his heart continued to look quite good and his exercise capacity was wonderful.
Ironically, when I got the VAD implanted, I looked right at him and said, "This thing's coming out." It was at 2 years, and it came out. I was really happy day, that's for sure. And then to get it out couldn't come soon enough, I can tell you that much.
So if we were to look at all patients with VADs, about 5% of them are lucky enough to actually get the VAD explanted. And the patients who tend to get better are people just like Matt, those who don't have coronary disease as a cause of their heart failure.
Even with this amazing technology, these results would not be possible without the seamless collaboration that makes the Heart and Vascular Center unique.
At the Brigham and Women's Hospital Heart and Vascular Center, we had a constellation of physicians, surgeons, pharmacists, social workers, and nurses who came together towards a single unified goal amidst great uncertainty, and that was to heal Matt Fogg's heart.
Everybody at Brigham, it's like a fine-tuned machine. The fact that everything was in one place at Brigham's was incredible. It made it really easy for me.
As rare as explantation currently is, Matt's case still provides much more hope for the future.
We want to usher in an era where patients like Matt Fogg with advanced stages of heart failure will have recovery of their heart function as the norm rather than simple support.
If you want the best care, you absolutely go to Brigham.
For Matt,
All right, so again, we have another young person who is experiencing heart failure and was able to have a better outcome. So again, the earlier we can intervene with these, the better it's going to be. Okay, yes.
Did they say what caused his heart failure in that video?
They did in the video, sometimes there are genetic issues, so with his, he didn't have any coronary heart disease, so it could have been something like that. They did mention, what was his complication with this? Stroke. With stroke, right? So again, anytime we are manipulating the blood and kind of diverting it different places, we do have a risk of an embolism formation, like thrombus formation, okay? So, practice questions. Do you like these or not so much? Yes. Yeah. All right, you have a client whose ejection fraction is 45. Okay, what does that mean? Can I move this? Great. This is a static question, so let's all apply. Thumbs up. Okay, so tomorrow when we're in lab, we're going to talk about the best way to approach select all and apply questions, if these are something that you struggle with. Okay, so what did you choose for your answers? A, B, C, Z, E. Okay. So A, B, and D. Okay, so that would be, they're considered to be a heart failure, right? What type of heart failure specifically? Which one have a preserved ejection fraction? Who said systolic? Nice word. Okay, the heart is not pumping, reduced cardiac output, yep. And the emptying 45% with each beat. So C is if it is not pumping effectively, edema to the legs and crackles in the lungs. Yes, we want to see. And are we going to have warm extremities and nice strong bounding pulses in heart failure? No, we're not. Okay. Next one. This one's also a slip all that apply. So which of these are we gonna expect? We're gonna expect A, shortness of breath, C, slow refill, and E, which is tachycardia. Okay. And we often, again, with that perfusion, cool clammy skin, and we know that a BTNP or BNP of less than 100 indicates no heart failure. Okay. Another one, left-sided heart failure. Okay, you have the slide, you can. What do we want to see? So left affects what particular portion? The lungs, all right, so which ones are we gonna pick? We're gonna pick C and D. So rest of the body is right failure. Okay, and then Shane Stokes respirations, when do we see that? When you're dying or sleep apnea, central sleep apnea, sometimes we have that. Okay, so I don't know if you can see this, if you have your PowerPoint or access to it. This is 3 body systems and 3 different categories of interventions. So if you have a client who comes into the emergency department with CHF and we see poor perfusion, okay, what does that look like in each of these systems? Okay, so it can be more than one. So under neuro, we have altered mental status, following commands, and alert and oriented. So which one of those are we gonna see in a person that has congestive heart failure? What's the neuro ramifications of this? Altered mental status, right? Why? We have poor perfusion, we have poor cardiac output, getting less oxygen places, okay? We have the kidneys. We have reduced osmolarity, low urine output, less than 30, or increased specific gravity. Okay, less than 30, she said increased specific gravity. Okay, and then our heart. What are we gonna see? Skin that's warm, bounding peripheral pulses, or hypotension? Hypotension, yeah. So the first sign is gonna be our altered mental status, right? Less of that renal output, so less than 30, and we're gonna have an increase in the specific gravity. Okay, because it's not reabsorbing, and we're gonna have poor perfusion, right? Okay, does that make sense? I know it was like a little bit of a fast review, but then is it okay with that so far? All right, 10-minute break. We're gonna come back and hit the next part. Alright, so we covered CHF real fast. Okay, hopefully that was a good reintroduction. Now we're gonna transition into something that's probably newer, and that is hemodynamic monitoring. Okay, so this is the stuff that when you think of critical care nurses and you think of all the lines and the beeping and the modules and things, this is what we're talking about. Okay, because if your heart is not working, you need metrics, you need data to figure out where and why and see how healthy it is. So our 2 goals of our hemodynamic monitoring is we're gonna look at your cardiac and circulatory function. And then we're gonna use it to see if what we're doing is making things better. We're gonna see if our interventions are working. Okay, a lot of them have to do with indwelling catheters. So these are external things that we are putting in different places, different tubes and wires, so that we can get a real accurate view of what's happening in real time. Okay, and then we use these for lots of different things. So you won't just see them for heart, you'll see them for anything that is critical care. Okay, even things like burns, trauma, traumatic brain injuries, those type of things. But for our purposes, heart failure, CABG, cardiogenic shock. We were going to cover cardiogenic shock for this week, but I just think it's too much, so we're gonna put that on the back burner and we're gonna talk about it next week, so it's not on this exam. But the hemodynamic monitoring is. Okay, so when you are putting tubes and wires in people to get real-time data, we do have lots of risks we have to acknowledge, right? So they don't come without some complications, bleeding, obviously, and hematoma formation. Because of the area where we're putting these tubes in, you may sometimes get a pneumothorax or a collapsed lung. We may irritate some myocardial tissue and have some dysrhythmia. Always have the risk of embolism or thrombus, and then nerve injury, right? So, but we have to do a risk benefit way to see if it's going to be worth its while. But here are the three types that we're going to talk about. One is an arterial line, arterial blood pressure. One that measures central venous pressure, and one that does pulmonary artery pressure. And all of those we are going to look at cardiac output. So those are the types that we're going to talk about today. Okay. First thing we have to know is, I think 1%, is it Riley? Are you the one who said mean arterial pressure? We were talking about our heart patient, which is awesome. So mean arterial pressure. When you look at your blood pressure monitor, right? When you take those like the Dynamap or whatever, you'll have your systolic, your diastolic, and in parentheses, you're gonna have that little number off to the side, right? That is your map, your mean arterial pressure. And that is if your heart is not squeezing, so it's in that filling stage, right? What is the average pressure in your arteries at that point? And we want it to be 80, right? That's a normal. We really want it to be above 60. 65 is our cutoff where we are perfusing our tissues, we're perfusing all the organs. We'd love it to be closer to 80, but our goal is always to be above 65, okay? So the worse you are doing, the more advanced your shock or critical condition, it starts to creep below 60, you start to see a lot of complications and signs of poor perfusion. So an easy way to do this is to take your blood pressure, right? Or to use the monitor, it gives it to you automatically. But if we want the pressure with each heartbeat, we don't want to wait for it to take with the Dynamap, we use an arterial line, okay? If we don't have one, here's two different ways you can calculate it, okay? So if I take a manual blood pressure, or I look at my little Dynamap thing, I can do it. I take my systolic blood pressure, I multiply my diastolic twice and divide by 3. Or you can take your systolic, subtract your diastolic, divide that number by 3, and then add the diastolic again. So there's two different ways you can do it. Both come out to the same. Okay, so if for some reason you don't have an art line, all you have is a blood pressure cuff and just your own knowledge and pen and paper, you can calculate your math. Okay, so one of those two ways, whatever makes more sense to you, at least understand how to calculate it. But if we need it in real time, one at a time, with each beat, we're gonna go to an art line or an A line, depending on where you work. Okay, most commonly we put it in the radius, the radial artery here. But just like we talked about, we have to make sure we have the patency of the radial artery, okay, using that Allen test. And what we're gonna do is it's gonna constantly measure our blood pressure, both diastolic and systolic, and our MAP with each heartbeat. Okay, it is the most accurate pressure you're going to get. Also, because it's right into that artery, we can use it for ABGs. We can do all sorts of arterial draws off of there, and we don't have to re-poke the patient. Yes.
How does it measure that with that line? Are you gonna go there? Okay.
No, great question. Okay, so what it does is actually it puts in a line, okay, that sits right in here, and it measures it with a transducer. Okay, so what you do is you set up a pressure bag so that we're not infusing, right? We don't put anything through this line, but we have equal pressure in that bag, and it reads against the pressure in the artery. And when it is zeroed correctly, meaning it is lined up, we can look at this waveform. And with each heartbeat, right, as it passes through that little catheter in the arm, it's gonna let us know whether or not it is a good sensing, a good tracing, and then it'll let us know what it is for each heartbeat. I don't know the finer points of it, other than there's a lot of equipment that goes with it. Kevin is gonna talk about this tomorrow, and here's a video on how to set this up. But it's a combination of using this little device here, it's called a transducer. And then there's a kind of cable that connects, so it has its own little box, like a monitor, like a cardiac monitor does. And then you can follow the waveform. So when you have on this patient, you're gonna have your cardiac monitor, and then you're gonna have your art line module right next to it. Okay.
Who are placing these in the hospital?
Physicians place them,
Okay.
or
Bedside or?
providers, bedside. Yep, this is bedside. You would put this in just like you would put in a central line, just like you would put in, say swan catheter, but that's me, anything to you. But they can put these in at the bedside as a sterile procedure, and then the nurses are the ones that monitor them.
How long's the catheter inside the,
How long can you leave one in?
no, I mean, how long's the catheter inside?
It isn't that long. It actually looks like a regular, angiocath. It is longer, it has a larger diameter, but it doesn't thread anywhere. It just stays right in here in this artery. Kevin's gonna bring one tomorrow. So he will be able to show it, you can look at it and he'll explain it. It's hard for me to do it without it in my hand. But if you watch this video, they'll actually show you how to set it up. And so the hardest part is making sure that you have your tubing primed the right way, a pressure bag to make sure that you have static pressure in there. So we don't want to infuse anything, but we don't want the pressure, because with an artery, there's pressure, right? We don't want it backing up into our tubing. And then there are these little stopcocks to make sure that you have all of the air taken out and that we have it aligned with where your heart is. We're gonna get into that here in a few minutes. But you line it up just right so that we have a baseline, and then anything above there, you're gonna get a good tracing. Again, it'll make sense tomorrow when we actually see it, just understand the dynamics of it, okay? When you have a patient with an art line, you're gonna make sure, looking at that module, you're gonna make sure you have a good waveform, okay? And so every so often, you're gonna make sure you correlate it with an external blood pressure just to make sure it matches, right? Just like when you have a patient with an EKG or you're trying to get an idea of what their waveform is, you take their pulse, make sure it matches. You have to make sure you're assessing the limb wherever it is. If it's femoral, you go in the leg. If it's radial, you go in the hand. But we want to make sure, because we are semi-occluding that artery, that we have good perfusion. We change the saline bag, again, that pressurized bag. You're going to change it every couple days, and we're going to have to zero it correctly. Okay. Do not use an A-line for anything administration. You can pull stuff off. You can pull an art line, an ABG off, but we do not infuse anything into there. Okay. For tomorrow, before you go to lab, this video is in your module and it says, please watch prior to lab. It'll go through it. Okay, it'll go through exactly what you need to know. It's about a 10-minute video, so it's got lots of tips and tricks. Okay. Questions on nursing care? And when you see it tomorrow, you can ask Kevin a bunch of questions. Because once you actually see it, it makes more sense. Okay. Another one we're going to talk about is we're measuring the arterial with the A line. We're going to do the venous pressure with the CVP line. Okay. And this is actually more invasive. This is going to be threaded up to just up at the top of the superior vena cava or into the right atrium. And that's going to measure right there in real time the blood volume, the return, and the pressure that's in that right side of the heart. Okay, so remember, everything's coming back from the body, it's dumping into that right atrium. So that's where it's going to be to get our information. This has a wave, but it correlates with what's happening in the heart. So like we have this PQRST that shows the electrical system. This CVP waveform is going to follow what's happening in the heart as well, as far as the contractions. Okay. Normally it's 2 to 6. It's measured in millimeters of mercury. If it is low, again, then we know we've got a cardiac output problem. If it is high, it makes sense that if we have a lot of extra blood volume, like in CHF, right? We're not getting everything pumped. So it's going to be higher in CHF and fluid overload. Okay, so if the test question said you have a patient who has CHF, what would you expect the CVP reading to be? You would say you want it to be higher, right? Because it's got more venous return. Does that make sense? Okay, so this is the same procedure for both A lines and CVP lines. Okay, and this word is phlebostatic access. So you're gonna lay your patient flat as they can tolerate, even if it's for a little bit, they have to have the head of the bed down. You're gonna take this IV pole, and it's gonna have this little brick, this little plastic placard, and you're gonna lower that right and even with their heart, and you're gonna get everything lined up and you're gonna zero it. Okay, because this is the most accurate point of the aorta, which you need for the mean arterial pressure. And it's at the right spot for the right atrium, which is where you need for the central venous pressure. Okay, so all this to say, it's not gonna be accurate unless this is accurate. Does that make sense? I've seen people try to like get it art line reading and the patient's like sitting up in bed and they can't figure out why it's not working. It's because you didn't start at a good baseline. Okay, so make sure that everything is zeroed right, and then you're gonna correlate it with a good blood pressure for the A-line. Okay, I'm gonna show you an animation on how to do this. This is not gonna be the same as what like Kevin will be able to do, but this is from the manufacturer on how to do this. So this isn't a real person, but it gives a good kind of overview.
Intravascular pressure monitoring setup with the TrueWave transducer. Part 1, priming the system. Bedside measurement of intravascular pressures is a basic tool in the care of the critically ill patient. TrueWave disposable pressure transducers can be paired with Edwards Vance systems to create a single integrated pressure monitoring and closed blood sampling system. TrueWave transducers are available in single, bifurcated, and trifurcated forms to suit your patient needs. The following animation demonstrates best practice in the setup of a single TrueWave disposable pressure transducer. Here's what you will need to get started. 1 TrueClip holder or an arm mount strip, a 500 or 1000 milliliter normal saline IV bag, a properly sized IV bag pressure cuff, and appropriate cable that connects your bedside patient monitor to the TrueWave transducer. Prepare the TrueWave transducer using the following 5 steps. Step 1. Using aseptic technique, remove the transducer kit from the sterile packaging and ensure all connections are secure. Step 2. TrueWave transducers can be mounted on either an IV pole or on the patient's arm. The setup procedure is the same. This video demonstrates the pole-mounted method. Insert the TrueWave transducer into a mounting backplate that is secured on an IV pole. Step 3. De-air the IV bag and prime the TrueWave system. Invert the normal saline IV bag so air raises to the base of the bag. Anticoagulation per institutional policy. Spike the IV bag with the fluid administration set, keeping the drip chamber upright. Open the roller clamp on the IV set. Open the vent port by turning the stopcock toward the patient's pressure tubing and away from the transducer while leaving the vented cap in place. While keeping the IV bag inverted, gently squeeze air out of the bag with one hand while pulling the snap tab flush device with the other hand until air is emptied from the IV bag and the drip chamber is filled at least halfway, or per institutional policy. Insert the IV bag into a pressure infuser bag and hang on an IV pole approximately 2 feet or 60 millimeters above the patient. Confirm that the IV bag hook is securely hung on the IV pole. If not secure, the IV bag could fall out as the pressure bag deflates. Do not inflate the pressure bag. Step 4. Prime the TrueWave system to gravity to avoid microbubbles in the line. Pull the snap tab flush device to deliver the flush solution through the TrueWave transducer and out through the vent port's vented cap. Remove all air bubbles. Close the vent port by turning the stopcock toward the cap. Holding the pressure tubing in an upright 45-degree angle, pull the snap tab to flush the remaining part of the line through the end of the tubing. Visually inspect the line to ensure that all air bubbles are removed. Pressurize the IV flush solution bag to 300 millimeters of mercury. Turn stopcock toward the pressure bag to lock off air pressure. Intermittently assess pressure during use, as pressure decreases when fluid leaves the IV bag. Low pressures in flush bag may lead to dampened pressure waveform and incorrect readings. Pull the snap tab to flush the system under pressure while tapping on the tubing and stopcocks to remove any residual bubbles. Step 5. Replace all the opaque vented caps on the side ports of the system stopcocks with non-vented caps. We have now completed priming the system. Please continue to part 2 of this video series, Calibration, to complete the setup of the TrueWave track.
Okay, so where they have that, we call it a nipple or whatever you call it, your facility, you're gonna pull that out. You're not gonna be free priming things because any little bit of air is gonna cause, number one, you're in an artery or you're in the chamber of the heart, depending on which device you're using. But as that air bubble travels through, it's gonna give you an inaccurate reading. So you wanna be very careful when you prime it. Okay, so does that give you kind of an idea of what you need to do? Okay. So they're actually really nice, especially when you have a critical care patient, because you're taking your blood pressure like every, 15 minutes or whatever, you can do it that way. But this, I can see with every single heartbeat, what's happening. With the A-line, I can see what the blood pressure is, or I can see what my venous return is. So if I give my medication, I can look at my CBP line and see right away if it's working. So advanced critical care kind of stuff, right? We good on those two? Similar, we do different things, but similar setup. Okay, this one is called a pulmonary artery pressure monitor, right? So this one we actually call a SWAN or SWAN dance, or those are the 2 people that invented it. Okay, it has 4 lumens right here, so 4 different things, and this one actually goes through the heart. Okay, because where you want it to go is you start at the top and you're going to thread this in. So you're going to go in through the neck. You're gonna go down into the heart, you're gonna thread all the way through the right atrium, the right ventricle, you're gonna go into the pulmonary artery, and this has a little balloon on the end that's gonna float into a offshoot of the pulmonary artery in a capillary. Okay, and they're gonna leave that little tip there, and it stays in there the whole time. When it is inflated, it'll tell us what's happening with the left ventricle, right? The pressure against it. When it is deflated, you can measure all these pressures, right? So when you want it like all the way down in and wedged in that capillary, you inflate the balloon, and then it'll tell you all about the left-sided filling pressure, right? And what do we call that? We call it a wedge pressure because it is wedged in there off of the pulmonary artery when that balloon's inflated. You can also deflate it if you need to get a different reading in that same area, but most of the time, we're going to call that the pulmonary artery wedge pressure. Make sense? Okay. It looks at your left ventricular function. This one we want between 8 to 12. Okay, so what does that tell us? If it's high, again, there is lots of pressure against that balloon, and so that tells us there's left ventricle failure, or you might have some tamponade, which we'll get to next week. And again, if it's low, there's not enough volume, right? So all of these have to do with real-time measurements, and this can let you know that they have low volume before you have to wait to take your blood pressure to find out that the systolic is really only 70 and your MAP is 52, right? This can tell you with each heartbeat what's happening. Okay. When you look at this, there's all sorts of different waveforms, and each one just correlates to where it is in the heart, right? So depending on as they float it through, what you're going to see. Okay, I'm not going to test you on that. Just understand that its position gives you a different reading with each one. Okay, and for tomorrow, we're going to have you look at this video. Again, it's in your lab module, and watch it prior to class, so that you have an idea what you're looking at, so you can ask some good questions and kind of understand what you're seeing. Make sense? You want a quick break? You want to keep going? Keep going? All right. So what are the type of catheters that we looked at? What are the different hemodynamic monitoring devices? A-line, CBP monitoring, swan cat, which shows you what? Pulmonary artery wedge pressure. Okay, so you're gonna get a lot more, those of you that have been to the ICU, who's been to the CICU so far? Did you guys see any of these devices? Yes, so this is something you're gonna see on your rotations through. And I apologize, I got final confirmation, we are not going to the ER at Ohio Health because they're in kind of a free fall with people with administration, turnover, and those type of things, and they asked that we not go. So our experiences are gonna be limited to the CICU, the MICU, and the CVICU. So those of you that were really excited to go to the ER, you can always try to contact somebody and do an observation day, but it won't be forever. So I'm really sorry. Several people are looking forward to that. All right, so we talked about how these pressures, our wedge pressure and our central venous pressure might be high if we are overloaded, right? Or fluid overloaded. One of the other things that we're gonna see with CHF and fluid overload is then pulmonary edema, right? And what side in heart failure do you think you'd see this most? Left side. Yep, and back it up to the lungs. The left of the lungs and they're wet. So again, causes heart failure, MI, some type of valvular disease, or it could be as a result of trauma, sepsis. We're seeing it a lot in our drug overdose patients, okay? Or neuro, if your respiratory drive center is affected, okay? Medical emergency, highlighted and bolded. We think it's important to know about pulmonary edema. Yeah, because when we have our heart failure patients, one of our manifestations of that acute congestive heart failure is gonna be the pulmonary edema. Okay? So we see it in the cardiogenic side, that is what we're gonna talk about, which is having to do with the heart itself. Usually, if we see it with our heart failure, okay? And the increased pressure, because the left ventricle is not squeezing well, we talked about all those different ways it wouldn't squeeze well, backs up in the lungs, and as blood sits there in those arteries, and capillaries in the lungs, the fluid kind of leaks out, right? And so that's what happens. So when that fluid gets there, we can't get a good exchange of oxygen and carbon dioxide, and we're gonna see hypoxia, right? So these are our people that are super short of breath. When you lay them flat, they're gonna freak out and get super anxious and say, no, 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 I can't breathe. Because as you sit down, that fluid sloshes, right? When you sit up, it's heavier than air, so it sinks to the bottom, so they breathe better sitting up. You lay them back, they're gonna have a real hard time. Okay? If it is not heart related, there are some things that can cause it, near drowning, okay, that can happen. There's something called HAPE, which is high altitude, which is if you are not accustomed to be at elevation, for some people, that extra atmospheric pressure can actually cause the fluid to leak out. Again, pulmonary embolism, anything that disrupts the blood flow, and overdoses. This is an X-ray. You can see all this infiltrate. You see all that kind of like hazy, spotty stuff. That is all fluid, right? X-ray waves don't go through there. All these signs and symptoms are all lung related, right? So all the things that we talked about with left-sided heart failure, you're gonna see pink frothy sputum, kind of the hallmark. Trouble breathing at night. Again, laying flat, that fluid is gonna even up and it's gonna get to the top part of the lung. Where if you sit up, it sinks to the bottom. Labored breathing, shortness of breath, again, laying flat, crackles and wheezes, right? Make sense? Okay. And then when we're looking at the heart, not just the lungs, we're gonna see other things with it. So that poor tissue perfusion, that oxygen, carbon dioxide exchange, is gonna cause the heart to try to beat faster. You're gonna have low blood pressure, cold, clammy skin and cyanosis. That's kind of our hallmark, okay? And then that S3, that ventricular gallop, is gonna be in another thing where we listen to our heart sounds. That S3 sound only appears when you have fluid overload. Okay, it's that extra click. They are also going to have a lot of presentation of, I would say, feeling things, okay? They're gonna be super restless, they're gonna be really anxious. A lot of them have this very scared, something bad's gonna happen, I'm gonna die, do something. It's because they're not getting air, okay? And they're feeling that heaviness in their chest, because the body knows it's not getting oxygen, it does trigger something in the brain. So these patients are gonna be really squirrely. They're not gonna wanna leave their oxygen mask on, they're gonna try to get out of bed, they're gonna try to keep moving and try to move their body forward. As a reaction to that fluid creeping up in their lungs, okay, so it's gonna take a lot of. Therapeutic communication, right? We don't wanna like jack them up on things to sedate them because then they lose their respiratory drive, right? So what intervention from a respiratory standpoint is really good for pulmonary edema? Nebulizer can help the wheezing. If the problem is that the pressure in the lungs isn't enough to expel, what do we use to help to equalize the pressure when people are breathing? CPAP. CPAP or BiPAP, right? So we have extra pressure, which helps then push the fluid back into the vasculature. So a lot of times in these patients, the best treatment for them is to put on that BiPAP, right? External pressures that are pushing against. When they are nervous and restless and anxious, do they want to keep the BiPAP on? You can tell. So this is where you're gonna spend a lot of time in there doing your therapeutic communication, keeping everything calm and doing all the things, try to keep it on because it's gonna make them better. Okay, when you have pulmonary edema, this is where this wedge pressure comes into place. Remember that catheter is wedged into those lungs and it will have an elevated, right? What did we say the normal was? High end is 12, right? So 25, that tells you you're really fluid overloaded. And since it's right there in the lung, it's gonna get a real good reading. Okay, so here's the things that we're gonna do. They're over here, they're bolded in teal, because I picked teal, it doesn't mean anything. So when you have a patient that is in severe acute pulmonary edema, it is a medical emergency. We have to have advanced airway equipment ready to go. Because if we cannot get them to calm down, we can't get the fluid out of their lungs, we can't get them to tolerate the BiPAP, we have to make sure oxygenation is maintained, we've got to tube them. Okay, we're gonna make sure that we're checking the respiration. This is one where you're gonna put them in high Fowlers. Okay, we want that fluid down at the base of the lungs. We don't want them tripoding, but we do want them in high Fowlers. We're gonna try to do the BiPAP, CPAP. We're gonna avoid the ventilator if we can. And we're gonna try to get the secretions as clear as we can. Okay, so improve oxygen exchange, this is how we're gonna do it. The next thing that's really important for us is we have to look at their cardiac output because our respirations and our cardiac function are very much interchangeable, right? So we wanna make sure that we are using that hemodynamic monitoring. We are using good tele or EKG to get a good feel for what their heart is doing and how it's tolerating it. We're also gonna make sure we put in a catheter. I know we don't use indwelling very often unless it's really necessary, and in this case, it is medically necessary. We have to know that we're perfusing the kidneys, and the only way to know that is to know their hourly urine output. Okay, here are the meds that we're going to use. None of these should be that surprising, but we use them in this case. We're gonna use those diuretics, okay? We're gonna use morphine. Why do we use morphine? Decreases O2 demand. What else does it do?
Helps that restlessness.
It does help with some restlessness. It also is the vasodilator. Okay, so if we decrease their O2 demand, we dilate it out, keep them a little bit calmer. We don't want to knock out the respiratory drive, but it will keep them calmer until we get that fluid off. Okay. And the last thing that's really important is we've got to deal with that fear, that anxiety, that restlessness, because if they are just out of their mind with anxiety and just scared to death, you're not going to be able to get very far in your treatment. And we don't want these patients on the ventilator unless we have to, because chances are it's going to be really hard to wean them off, right? So we can do it. That's our go-to for our emergency plan, but we definitely want to make sure if there's a family member that keeps them calm, if there's something we can do, give them lots of reassurance, explain everything step by step what's happening. They have a pretty good output. All right. Questions. We're going to practice. There's a lot of reading on these. Okay. Move this to the side. I'm just going to take it off right now. So, 88-year-old. Look at their symptoms. Look at their vital signs. You wanted to know what type of test questions you're going to see. This is an example of some of the higher level questions. What do we use a BTNP for? Yep, we look and see heart failure. What signs in here show you that there is heart failure? What do we see? Symptoms, right? Right? Those are our objective symptoms: diaphoretic, sweaty, tachypnic, breathing fast and dyspneic, trouble breathing. Okay, then we have our vital sign, which is a SAT of 78. Okay, so when you're reading questions, pull out what you can that will point you in the right direction. Okay? Acute pulmonary edema. What do we think we're gonna give? Right, are we gonna give TPA? No. What is that? Blockbuster. We're gonna give a saline bolus? No. Why? Loaded. We're gonna give epinephrine? No, what does that do? Right, exactly. So we are going to go with the Lasix or the furosemide, which does what? Okay. What category is furosemide? Loop diuretic. What am I gonna watch for? Potassium. See, look at all these connections we make. You guys are awesome already. All right, acute pulmonary edema. What am I gonna see? Okay, green sputum. No. Worse than short of breath when upright. No, what is it gonna get worse? Absolutely, what's that called? Orthopnea, good. Tachypnea. What is that? Fast breathing. Dyspnea. What is that? Difficulty breathing. Crackles in the lungs. Yes. All right. If you need explanation on why, rationale or terminology, there you go. I'm not gonna go through all of that with you. Okay, green sputum, we really don't want to worry about that, right? That really has nothing to do with it. Do those NCLEX questions help you? Okay. Tomorrow,